Well, it's the top of the hour. I think we're ready to go. So, welcome to our program, Hiding in Plain Sight, a focus on diagnosing and addressing the unmet needs of homozygous familial hypercholesterolemia. I am Dr. Martha Gulati, and I am the president-elect of the American Society for Preventive Cardiology. I have no conflicts of interest, and I'm joined today by my colleague, Ms. Kathleen Byrne from the PCNA. Catherine, do you mind introducing yourself?
Yes, thank you, Dr. Gulati, and thank you to everyone for joining us this evening. I'm a cardiovascular nurse practitioner at Johns Hopkins in Baltimore, where I care for both adult and pediatric lipid patients, and I have no disclosures.
Well, our learning objectives are listed here. Our objectives tonight are to describe the prevalence of homozygous FH and its underdiagnosis. We're going to discuss how to apply cascade screening in clinical practice as a cost-effective strategy to diagnose FH in close relatives of patients already identified with FH. We want to outline how to integrate currently available therapies with novel mechanisms of action into the treatment regimes of patients with homozygous FH. And we're going to explain how to increase accessibility to the newer LDL lowering therapies for patients with homozygous FH. So we're going to start with some pre-test polling questions. And just for those of you participating on the webcast, please click your selected answers to all the questions as we're going to go through them one at a time and hit the submit button when you're sure of your choice. But if you're viewing this live stream through a social media platform like Twitter or Facebook, please use the links provided to complete the pre-test and then again for the post-test, because that's how you'll get the credit for your CME credits for this. So let's go to the first question, which is already, I believe, up and running here. Approximately what percentage of patients with FH are underdiagnosed? And your choices are A, 10%, B, 40%, C, 70%, or D, 90%. Just remember to press the submit button. And when we have the majority of you captured, we'll move to the next question. We'll give you the correct answers much later on. All right, great. The second question is listed here now. So same thing. 28-year-old female patient was recently diagnosed with homozygous FH. She has 2 children and an older brother. Based on diagnostic screening criteria, who else in her family would warrant screening? Either her children only, her children and her brother, all her first-degree relatives, or no one else should be screened. Make your selection. We're certainly seeing how that's trending out. All right, we can probably move on to the next question. The next question is a 27-year-old patient with a positive genetic test and confirmed diagnosis of homozygous FH. He or she is taking ezetimibe and rosuvastatin 5 milligrams every other day due to low tolerance of statins. Which of the following therapies would you recommend next? And your choices are Bempendoic Acid, evinacumab, continue the rosuvastatin only, or add evolocumab. And we're seeing a trend here as well, Kathleen.
Mm-hmm.
All right, and our last pre-test question. What practical strategies can the healthcare team provide to ensure the patient adheres to optimal medical therapy? And the choices are: suggest patients search for online education regarding treatment options before the next visit, Suggest the patient conduct a search for online tools or apps provided by national organizations. Direct patient to online resource or patient education provided by national lipid and cardiology associations, or recommend patients consider standard of care option to avoid insurance barriers.
Good.
Great. Well, thank you for answering those questions. And again, we'll get to what we think are the right answers at the end. We're going to start the presentation right now with Kathleen giving us an overview of familial hypercholesterolemia. So, Kathleen, take it away.
Thank you, Dr. Gulati. So I'm going to give you a brief overview of familial hypercholesterolemia, and we're going to talk about the two types, heterozygous and homozygous FH. So what is FH? It is a very common, life-threatening genetic condition that's associated with very elevated LDL cholesterol levels. In fact, it is the most common genetic disorder that's associated with lipid metabolism. And the elevation in the LDL cholesterol is present at birth. It occurs in all races and ethnicities. And in fact, you will find that in some ethnicities, it is more prominent due to what we call the founder's effect. So you will see it in French Canadians more frequently. You will see it in Ashkenazi Jews, in Afrikaners in South Africa, and the Christian Lebanese. And when FH is unrecognized and therefore untreated, it's felt that you will have, it is not felt, it is associated with premature cardiovascular disease and death. So it's very important to recognize it, because I must note that only 10% of all the individuals in the United States have been diagnosed. Only 10%. So 90% have not been diagnosed. Some individuals will have physical signs of familial hypercholesterolemia. They'll have cholesterol deposits around their eyelids, or they may have them in their tendons, but others have no physical signs at all. And in fact, I've heard many a time from patients, how could I possibly have elevated lipids? I'm really slender, and I eat a very heart-healthy diet. So that can't possibly be me. Now, we identify FH as either being heterozygous or homozygous. Heterozygous meaning that an individual has one abnormal genetic mutation that has been passed down from one parent to the child. So they are heterozygous. When they inherit an abnormal mutation from both of their parents, they are said to be homozygous. Familial hypercholesterolemia primarily follows an autosomal dominant pattern of inheritance. And most commonly, you will see the three most common genetic mutations being the LDL receptor, or LDLR, the most common, ApoB, and PCSK9. And less commonly, you will see a defect in the LDL RAP1 gene. We refer to that as ARH, autosomal recessive hypercholesterolemia, and this is inherited in an autosomal receptive manner. This particular phenotype actually has a milder presentation than the others. Currently, we have more than 2,000 variants that have been identified. Sometimes very interestingly, when we test folks, do genetic testing, the genetic results will come back of unknown significance, only later to have it be discovered that it really is a pathogenic variant. Okay, so again, the two pathogenic variants, heterozygous and homozygous FH. Just to recap, heterozygous FH is the most common form. It occurs in about 1 out of every 200 to 250 individuals. Remember, these individuals have received one genetic mutation from a parent. And we begin to think of heterozygous FH when the LDL cholesterol is at 190 or above in adults and about 160 milligrams per deciliter in children. But please keep in mind, this is not an absolute because the numbers can indeed be a little lower. We may begin to see the onset of coronary heart disease or so-called premature coronary disease anywhere from 30 to 60 years of age in these individuals, particularly when they are untreated. Most individuals respond to drug therapies, but again, it is noteworthy that it will involve more than one lipid-lowering agent. It's not just a one and done, even with heterozygous familial hypercholesterolemia. Now, homozygous FH is more rare, and it's the most severe form, and it occurs in every one in every 170,000 to 300,000 individuals. However, it's actually a lot more prevalent than when I started off taking care of patients with hyperlipidemia. I can remember 20 years ago when I entered the field, I was told it's 1 out of every 1 million individuals. Not so. Look what we've got it down to. But because we are looking, okay? We are looking for this. In homozygous, the patient is identified as having 2 genetic mutations passed down, 1 from each parent. The LDL cholesterol levels are markedly elevated, certainly greater than 400 to 500 milligrams per deciliter. And most recently, I think I've seen the highest I've ever seen, and that's when the LDL cholesterol was 1,000. So there's a great deal of variability here. The onset of coronary disease can definitely be during childhood, with the first MI often presenting in early adolescence, again, particularly if not treated. Physical findings are certainly present, and Dr. Gulati will discuss these in a little bit. Now, the management of homozygous familial hypercholesterolemia is certainly more difficult or challenging, I should say, than heterozygous familial FH. And it requires multiple medications and or treatments, including LDL apheresis. And despite the approval of several new drugs in the past decade, it remains a challenge to bring individuals closer to their stated goals. This may be because of a less than optimal response to some of our available drugs or concerns with safety and tolerability. I want to move on and just take a look at a family tree here. Remembering we have HeFH off to the left, that's our pedigree there. Just remember that children of an individual who has FH has a 50% chance of inheriting this disease. It is so important for us to screen early on, because if we screen early, we can certainly get these folks on early treatments and save lives. Now, if you look at an individual who has HoFH, so look at that pedigree to the right, parents who each have heterozygous FH have a 25% chance with each pregnancy of having a child with homozygous familial hypercholesterolemia. They have a 50% chance of having a child with heterozygous FH and a 25% chance that child will inherit a normal gene from each parent. And I just have to apologize to you all. Obviously, you can hear my voice. I am home here with COVID. And so this is the first day I've had a voice, and I certainly appreciate your patience with me. I'm now going to turn this back to Dr. Gulati, who will discuss screening and diagnosis.
Thank you, Kathleen. Yeah, you're a real trooper, even doing this with me tonight. I'm just in awe of you, given where your health right now is. And she's on the mend, though. Even from this morning, she sounds a bit better. So I'm going to talk about, are we missing the diagnosis? And clearly we are, based on what you heard from Kathleen. 90% of people with FH go undiagnosed. So what we are missing the diagnosis in many patients. And why does that matter? Obviously, when you have familial hypercholesterolemia, particularly homozygous FH, that version is associated with life-threatening risk, cardiovascular risk, but at very early ages, as you already heard. But I like this figure that we've shown here. You can see the blue line representing homozygous FH, and you can see at very young ages, at less than 10 years old, we can see evidence of atherosclerotic cardiovascular disease. Patients can already have, with these increasing LDL levels, they can already start having cardiac events, including myocardial infarctions in the first decade of life. And mortality can also, within the first and second decade, when these patients are untreated. So the mean age, just so you should be aware of of somebody untreated with homozygous FH, is for being diagnosed with some form of atherosclerotic cardiovascular disease is 12.5 years. So 12.5 years. So many of those patients do not see adulthood. Now, if you have heterozygous FH, you can see that the trajectory of both the LDL raising as well as the threshold for coronary artery disease is delayed. It's still greater than the general population, and certainly young adults with FH have a 90-fold increase in mortality due to cardiovascular disease. So we don't want to miss this disease. Unfortunately, we do all the time. Now, it would be nice if there was physical findings that were jumped out at us and screamed FH. And you already heard from Kathleen that many patients will have no signs or symptoms, actually, in terms of us being able to make this diagnosis. When they do, certainly recognize them for FH. Here's just some examples. This is an example of cutaneous xanthomas. This is actually in a 3-year-old patient, and you can see them on the wrist and also on the ankle. The discoloration here is highlighted quite well. There's tendinous xanthomas that can be seen on the fingers and also on the Achilles tendon. Is a place that we often see it. And so people wonder why I go down to the ankles to examine patients, but this is the main reason. Now, certainly xanthelasmas, can be present in patients with FH, and certainly noting patients with this should at least alert us to know what their cholesterol is. Corneal arcus is an example, is shown here. So those are signs. Now, symptoms that they may have are things like chest pain, claudication, poor wound healing, and obviously, if they've had a cardiovascular event, particularly those at a young age, you should think, does this patient have FH? Because they may not have any of these physical findings. I like the example of Mona Lisa. And the reason is because we believe the reason Mona Lisa was both painted, but also the reason that she died very young was probably she had FH. And there has actually been very interesting articles, maybe some of you have read them, where they actually said that if you look at her hands, that she had xanthomas and that her eyes also had evidence of xanthelasma. And she did die at a very young age, in her 30s. So the belief is that Mona Lisa had FH. So just think about that and remember that when you're seeing patients with these findings. In terms of FH, we've already said it's vastly underdiagnosed and undertreated. We can't say this too often because we're trying to convince people to look for this disease and treat this disease. You already heard these numbers, that it's highly underdiagnosed. And I too learned that it was very rare and I probably wouldn't see it. And I've spent a big part of my clinical time seeing and treating patients with FH. So the estimates are that there's 14 to 34 million people worldwide who have FH. And again, 90% of patients are undiagnosed. The biggest problem, I would say, is that we don't screen children, despite guidelines clearly saying we should be assessing cholesterol in children at the age of 9 to 11, somewhere in that range, and not enough children get their cholesterol screened. Additionally, we do not do the cascade screening enough. In our first degree relatives of any patient identified with FH, all their first degree relatives should get screened, and it doesn't happen enough. Certainly, we need this is a worldwide need. This is not unique to one part of the country, one part of the world, as you already heard. And there's many barriers to the FH diagnosis. One is obviously education and recognition. I already said that children often don't get screened, even despite guidelines through the American Heart Association encouraging this. There's obviously using our electronic health records could be an easy way to identify this, but again, it's not used often in this way. And we need to implement screening and diagnosis guidelines more into our clinical practice. So there's many different ways to diagnose FH. You might be more familiar with things like the Broom criteria or the Dutch Lipid Clinic criteria. Those are probably the two most common used. The American Heart Association now has given diagnostic criteria as well for adult and pediatric patients, and they're listed here. And it was to make it easier. To be honest, that's why these criteria came out, because I think the barrier was implementing the other criteria, that it was sensed as too complicated, or you had to go to some tool and you had to give a score and then decide it. Many of us do this in our lipid clinics, but certainly you can see here for heterozygous FH, for children, if their LDL cholesterol is above 160, or for adults when the LDL cholesterol is above 190 milligrams per deciliter, and where there's a first degree relative who has already been identified with a genetic abnormality, they may have other genetic testing done as a result of that might increase the diagnosis of heterozygous FH. Heterozygous FH, we often think of not being as high, but there is some patients that will have LDLs even as high as 400, but you will eventually decide that this patient actually has heterozygous FH, whereas homozygous FH, commonly the LDLs are very high. Above 400 is part of the diagnostic criteria, again, with a strong family history, with a family history of FH as well, may have genetic testing as well. But there is also some homozygous FHers who will not have an LDL above 400. So we can be surprised many times. There may be clinical findings as well, aortic valve disease or xanthomas at young ages. Again, taking the family history is so important of a first degree relative. Again, they might have confirmed FH. They may know the family's LDL. They may just only know, though, that people died prematurely of cardiovascular disease. And so you just have to use the patient in front of you to decide that. For pediatric patients, what we recommend and what the guidelines say is having 2 LDL levels obtained at least 3 months apart that are above 190 milligrams per deciliter, or if they have an LDL above 160 in the presence of a family history of severely elevated cholesterol or premature coronary artery disease, you will make that diagnosis of FH. So again, genetic testing is really an opportunity to identify FH and prevent cardiovascular disease. The reason it's so important is when you identify somebody with FH, you immediately would hopefully get started with the cascade screening and not just treating the patient in front of you, but identifying at-risk individuals in the family. In terms of genetics, we have these discussions with our patients and our genetic counselors. These are often part of any lipid clinic, particularly clinics that have patients with FH, which I would actually say most of them have patients with FH. It promotes getting the genetic testing promotes the definitive diagnosis and can subtype them into heterozygous or homozygous groups. It eliminates the need to investigate secondary causes of elevated LDL. Often, unfortunately, that already up front, though, before they get to the right place. It identifies variants associated with a higher cardiovascular risk, or even sometimes those with a lower risk, as you heard from Kathleen's description of some of the subtypes. It improves initiation and adherence to lipid-lowering therapies to delay cardiovascular events and early cardiac death, and cascade screening, as I already said. Now, there is barriers. There's cost concerns. Not every patient can afford genetic testing. There's also a discussion with our genetic counselors about life insurance, and that sometimes can be a deterrent for patients to get these tests done. And that's why really involving a genetic counselor, I think, is key. There's certainly sometimes the patient will have a belief that the results won't change the treatment decisions. And even in our medical community, they'll say, I'm not going to change how I treat this patient. I'm going to treat them aggressively. I don't need the genetic testing. So sometimes that might be the reason. I still would like it, though, for cascade screening if again, the patient is willing and the cost doesn't prohibit it being done. So again, we can't say enough about the importance of cascade screening because we identify other people at risk. And so with all of these patients, when we identify these extremely elevated LDL patients, we will do the family tree. We'll build it out. You'll see any genetic counselor will create these immediately on their first visit. And again, the barriers we've already talked about and the benefits we've already talked about of doing this. But it can help us with the patient in front of us as well as potentially family members. So now Kathleen is going to discuss the treatment strategies and the guideline recommendations. So I'll let you take it here.
Okay, thank you. So we are going to, again, talk about some of the treatment strategies and guideline recommendations in order to optimize lipid management in patients with homozygous FH. So treatment considerations. First of all, I think as a basic tenet, we all know that we want our patients to eat and have a healthy dietary pattern, to be physically active. If they have any other risk factors, such as being overweight, then lose that weight. And particularly to avoid tobacco usage. And if they are smoking, to work with them for smoking cessation. Now, the initial treatment of homozygous FH is actually identical to that of heterozygous FH. So they're exactly the same. Statins remain our first line of therapy, and they do definitely impact mortality in a positive way. They are used at the beginning of the diagnosis, both in adults and in children. And again, then you can have the very rapid addition of ezetimibe and PCSK9 inhibitors. However, the responses that you will see in individuals to these therapies really vary depending upon the residual LDL receptor activity that they may have in their carried mutation. So individuals who have mutations with undetectable or what we call negative or null receptors will have a very decreased response to the drugs. And when I say a negative or null response, that means they only have anywhere between 0 and 2% of receptor activity. And that's opposed to those who have more residual receptor activity. And we call those people LDL receptor defective. And those individuals have anywhere between 2% and 25% receptor activity. So statins, ezetimibe, and PCSK9 inhibitors. All three of those rely on what they do is upregulate the LDL receptor. So you can see that you're going to have variability in your response depending upon how much receptor activity is available. Now, I want to make a couple of comments about PCSK9 inhibitors. Evolocumab was used in patients with homozygous FH, and in a 12-week study, in 49 patients who were on stable background therapy that did not include LDL apheresis, their LDLs decreased an additional 31%. That's significant. Every percent that's decreased is significant to us. And then in a long-term outcome study, either 420 milligrams monthly or the standard every other week therapy was used. There was an additional 24% lowering in LDL cholesterol in about 100 individuals, in whom about 1/3 were receiving LDL apheresis. Okay. All right. So there we go. Let's go on to our next slide and look at this algorithm for the treatment of adults, meaning greater than 15 years of age, with HoFH. And this will certainly need to be updated, but we diagnose the person to have FH homozygote, an FH homozygote. And it's important that you consult with lipid specialists or cardiovascular providers who are expert in the management of homozygous FH. So they started the statin at the maximum tolerated dose. And this is high intensity statin. So it would be atorvastatin, high density 40 to 80 milligrams, or rosuvastatin 20 to 40. This is not the person that we put on pravastatin, okay? And I mean this as well in children. We use the high intensity statins. So you use a statin and you consider then, am I going to add on ezetimibe, PCSK9 inhibitor, an MTP inhibitor, a resin, or Probucol in combination. Now, Probucol it was taken off the market, I think, in 1995 because of some cardiac effects. But I want to say a word about right here, MTP inhibitors or lamidipide, which is a microsomal triglyceride transfer protein inhibitor. And when it is added to background lipid-lowering therapies, including LDL apheresis, it has been shown to have a 50% decrease in LDL cholesterol at average dosages. Now, this is a medication that is approved only for homozygotes and is extremely expensive at this point in time. And then when folks were followed on the long term for over 5 years, despite the safety concerns that we have had for lamidipide, being of fat accumulation in the liver, the hepatic fat actually stabilized, and there were no signs of insulin resistance or systemic, I should say, inflammation. Okay, so if you go down this route, okay, if you're on max stat and your LDL cholesterol is certainly greater than 70 milligrams per deciliter, which invariably it's going to be, adding ezetimibe is reasonable. If a PCSK9 is considered, add that on. Ramp these up very quickly. Okay, very, very quickly. The other thing that you can do is to initiate LDL apheresis. So standard of care and unmet therapy needs. We're going to talk a little bit about that. But so again, here are the traditional medications and treatments that we use. Statins, an HMG-CoA reductase inhibitor, ezetimibe, which acts on the MPC1L1 receptor, and we can see some reduction, perhaps, in LDL cholesterol. You may want to add on a bile acid sequestrant. It's not going to get you any more than about 10% to 15% additional LDL lowering. It's a lot of pills that you have to take, and it can have GI side effects. If the patient already has increased triglycerides, it may increase them further and be prohibitive in its use. So again, they may not see much benefit. Again, try alirocumab and evolocumab, the PCSK9 inhibitors. Depends upon what percentage LDL lowering you're going to get. Will be dependent upon your residual receptor activities. And then LDL apheresis. This is where we are removing the LDL cholesterol from the plasma. It will definitely lower the LDL cholesterol by about 50%. The problem is that this is an invasive procedure. It says here that it lasts anywhere between 1.5 to 3 hours. I'm going to tell you it's really longer than that by the time you set up, and your flow rates may have to be adjusted. This definitely impacts individuals' quality of life. Can you imagine every 2 weeks having to go and have this treatment done? However, if that's the only thing that's keeping you going, then you do it. And it's a high price to pay. Each treatment is about $2,500. So you figure if you're doing 2 treatments per month, it's about $60,000 per year. Okay, now, let's see here. Oops, I want to go back. Oh my goodness, here, let me just go down. I flipped too quickly. Okay, so your PCSK9 inhibitors, just want to tell you, remember we said that you could see some 30% additional LDL lowering. Remembering that alirocumab was also approved for treatment of HoFH in April, I believe, of this past year. So both evolocumab and alirocumab are approved to treat. And then finally, limitations. Let's just go back again and repeat this. Lamidipide, it can cause liver toxicity. Individuals are supposed to be on a very, very low fat diet. And I will tell you that is very difficult to maintain. And my homozygous FH patients were very young. Actually, when this drug came out, they were all on their way to college. And I don't need to say anything more to you about alcohol and partying. And so that was a real concern. Plus, they had to get their liver function tests done very frequently, and they had difficulty with follow through. So that's a problem. Again, statins, PCSK9s, bile acid sequestrants, and ezetimibe, I think we've said it. Your response is going to depend upon how much residual receptor activity you have, okay? And LDL apheresis, we see dramatic but temporary results. So that when the patient walks out from having a treatment done, a 4-hour treatment done, their LDL cholesterol may be down to 100, but over a 2-week period, that gradually tracks upward, okay? It's invasive, costly. Okay, so I think that's all I have to say about the standard treatments. And now Dr. Gulati is going to review the newly approved therapies in order to hopefully optimize patient outcomes.
Yes, thank you. So we're in a very exciting time for patients with homozygous FH because in the last few years, we've had new therapies approved, and that this is really a game changer. More lives that we are able to save and able to lower cholesterol more effectively. So these are the 3 of our newly approved LDL lowering therapies. Evolocumab, which is a angiopoietin-like 3 protein inhibitor. It effectively decreases LDL, but also reduces triglycerides. It's injectable and it's used at home. It can be an injection or an infusion. And it's approved now as of February 2021 for add-on treatment for adults and pediatric patients over the age of 12 who have homozygous FH. The dosing is 15 milligrams per kilogram IV infusion, and it's given over 60 minutes, and it's given every 4 weeks. And we'll go through their mechanisms of action. So the other medication is inclisiran, which is also a PCSK9 inhibitor, but it works different than the ones you just heard about. It is actually called a small interfering RNA molecule, and it inhibits actually the production of PCSK9 altogether. So it has pretty unique action. And we have phase 3 studies showing the dramatic reduction of LDL by over 50%. Again, this is an injectable. We have data supporting the reduction in cardiovascular morbidity and mortality that is ongoing, like in terms of trials that they're collecting this data. So it hasn't been determined yet, but it is a very effective drug at lowering LDL. And it was approved in December of 2021. It is obviously an adjunct to diet, as is every medication in FH. I mean, we really emphasize lifestyle as much as we do all these medications. And you want them to be on maximally tolerated statin, especially you can use it in patients with atherosclerotic cardiovascular disease or heterozygous FH who require LDL lowering. It also was designated as an orphan drug status back in 2018 for the treatment of homozygous FH solely on the dramatic LDL lowering. It is the dosing is really every 6 months, although initially you give the initial injection, then again at 3 months, then at 6 months, and then every 6 months thereafter. Bempendoic acid is also a new drug that is very exciting that lowers LDL upstream, even more upstream than where statins work. They inhibit the citric lysase, and that inhibits actually the production of cholesterol up front. So again, there is some limitations in the use in terms of hyperuricemia, tendon rupture, very small rates, but still notable rates compared with placebo. There can be drug interactions, especially if patients are on simvastatin or pravastatin. Again, we don't really like using those drugs, but some patients might be on this for a variety of different reasons. So you do have to watch for those drug-drug interactions. Again, it's adjunct to diet, maximally tolerated statin in patients who have atherosclerotic cardiovascular disease or those with heterozygous FH requiring additional LDL lowering. This is an oral medication, and the patients would take it once a day. So we'll go through these now a little bit more. So for our angiopoietin-like 3 protein inhibitor, we'll talk about that first. You can see the method of action is really the role of angiopoietin like 3. It inhibits lipoprotein and endothelial lipase, and that ultimately results in high levels of LDL and triglyceride. So this as a target, by inhibiting it, we reduce the LDL and reduce triglycerides as well. And we've seen that in our studies that the people who have a loss of this particular protein have low levels of LDL and low levels of triglycerides and lower levels of cardiovascular disease, actually a lower risk by about over 40%. So that is the mechanism of action of this drug. We have data showing, this is the phase 3 study called the Ellipse Trial, and this was showing the efficacy if you compare denosumab compared to placebo. You can see in both of these, whether you like the percent change or the absolute LDL change, you can see it shown here. And this was a study of 65 patients with homozygous FH. And you can see that the LDL was reduced by about 47% in 4 weeks' time after the IV infusion. So pretty dramatic reductions in LDL, and that's what got the FDA approval in February of 2021 for add-on treatment for patients with homozygous FH. Just so that we're all clear, we collect the safety data so that people are aware of what it compares into placebo. You can see here, in terms of any adverse events, these are pretty minor events, but still important to be aware of these events that were more frequently seen in patients in the treatment arm compared to placebo. But none of these adverse events were associated with discontinuation of either the placebo or the angiopoietin-like 3 protein inhibitor. So inclisiran, which I told you is the small interfering RNA molecule that inhibits the production of PCSK9 inhibitors, you can see the mechanism of action here. PCSK9, what it does is it causes elevated cholesterol by reducing LDL receptors in the hepatocytes. And inclisiran is actually this new mechanism of PCSK9 inhibition by targeting the RNA, the messenger RNA, for PCSK9. So it reduces the production of PCSK9 and therefore reduces the overall LDL. So pretty novel mechanism of a drug. And here you can see from the Orion 10 trial, you can see here that we get an effective lowering of LDL. This was, again, a phase 3 double-blind placebo-controlled trial. It was over 1,500 patients with elevated LDL. They were all on a maximally tolerated statin, and many of them were also on ezetimibe as well. And the LDL, those patients with an LDL above 70 on these stable lipid-lowering therapies were enrolled in this trial. And you can see there was a 52% reduction in the treatment arm of using inclisiran compared with the placebo arm. And this was as it was followed out over 17 months, that there was this continuous reduction of LDL lowering, which got the FDA approval again for this medication. Again, it was well tolerated over 18 months. The adverse events occurred in just the most common adverse events in over 3% of the patients. The commonest thing was injection site reaction, and you can see that obviously compared to the placebo. And that was obvious. Discontinuation was quite rare, actually, due to that compared to the placebo arm. The safety otherwise was across all subgroups it was considered a very safe drug. Again, it was not studied in patients with end-stage renal disease, and it was also not studied in patients with severe liver disease as well. So again, in those patients, this might not be the ideal drug to try because we don't know the effects in them. Lastly, bempedoic acid. Again, I told you that this is an inactive prodrug that once it gets activated, it works right in the liver, and it is selectively activated in the liver, not in the muscles, which may be the reason that there's a reduced likelihood of any muscle symptoms with this drug, but works ahead of where the statins work. So it reduces the production of cholesterol, but has this added benefit that you're not as likely to have any muscle symptoms that occur with this statin therapy. You can see we have a lot of trials with bempedoic acid that continue to come out here, and it just shown and summarized here. All the clear studies were studying bempedoic acid, as well as some other trials that are listed here as well. And all of these are showing that there's a reduction in LDL, a difference compared to placebo, and these were all statistically significant. So this drug, also a very novel drug, and particularly maybe beneficial in patients with statin intolerance due to muscle aches. The tolerability and adverse events are shown here. Again, this was not in any comparison of placebo, but just in general, the tolerability considerations that we tell patients to look for is certainly we screen for hyperuricemia or gout, and tendon rupture is a possible side effect. So you want to be in patients who you are worried about that or already have that issue, you might want to avoid this drug. There is some other adverse events, but we are waiting on long-term data now for this drug in terms of other safety effects in comparison to placebo.
Okay, so I'm going to talk a little bit about the very important role of patient education and some resources that are available to patients in the treatment of homozygous FH. And I'm going to tell you that, first of all, one of the most important tools is the utilization of yourself and your staff to educate your patient. We can have lots of pamphlets and handouts for them and be able to direct them to sites on the internet, which are definitely great. But I think that it's always important for us to continue to support them, to educate them, and be their biggest cheerleaders so that they continue to follow their therapies. There are some very important tools to improve family communication and to facilitate cascade testing. There are some Dear Family letters that are available that can be given to patients, and they can be sent out to individual families so that family members, so that they can consider cascade testing. There are guidelines in today's world because we're doing a lot of telemedicine visits. What kinds of things patients should have at their fingertips as they're ready to prepare for these telemedicine visits. It makes it much easier for them as well as for the providers. It's important for them to be aware of FH specialists, and we have those available to us as well. There are some blogs, there are educational videos and webinars and up-to-date news articles. I'm going to put a big plug in for the ASPC, as well as the National Lipid Association, as well as the Preventive Cardiovascular Nurses Association. All of these organizations have guidelines, not only guidelines, but educational materials that are written in a very patient-friendly mode so that patients can understand what is going on with them. We also have, it's very important with these newer drugs, to be able to get them reimbursed for the new lipid-lowering medications. I'm sure you all went through this with the PCSK9 inhibitors, and there are guidelines that are out there for what you should include in your notes to get them, to get the medications approved. There are also some brochures and toolkits that are out there. The representatives from the drug companies, the pharmaceutical companies, are very helpful as well. And there are also some online FH insurance guidelines. I would also tell you the FH Foundation, which is no longer the FH Foundation, but it's now the Family Heart Foundation, I believe, so it's even more encompassing, provides great information for patients. And I give all my patients the website for that so that they can get the most up-to-date information. And then here are these prior authorization forms. It's important that they be filled out correctly and thoroughly, as well as if you get rejected, first and foremost, try again. Do not give up. Remember, these are our patients that we're advocating for. And there are sample letters that are available as well. And then, again, here we have the Family Heart Foundation there, the Navigating Insurance Guide. So there are lots of tools that are out there to help us. And then I skipped something. Let me go back. Improving access. Again, I showed you that here are some of the tools that are available from the NLA, the ASPC, and the PCNA available as well. Okay. Now we're going to move on and see how well we internalize this information. We're going to take a look at a patient with homozygous FH. So this is Anna. She's a 32-year-old woman who has had her cholesterol screened as part of an annual exam. And when she comes in, her presentation, she tells you that she's been having some palpitations and some nonspecific chest discomfort over the last several months. She's got no stigmata of hyperlipidemia anywhere. And then, oh boy, you find out when you're getting your history that at her annual, since starting her initial screenings at 22, her LDL cholesterols have been consistently around in the low 400 ranges, 406 to 424. But she's been told not to worry because, after all, your HDL is high, so you are protected. How many of us have heard this time and time again? Not true. Now, fortunately, she's not had any prior cardiac events. From a lifestyle perspective, she's a smoker. And most importantly, when we look at her family history, there's a very strong family history of early onset heart disease and death. Her father died at the age of 38. Her brothers had an MI at 32. And previously, she had not reported any family history of cardiovascular disease. So family history is key. So she has an 11-year-old and a 2-year-old, both boys, and she does not plan on having any additional children at this time. So she was tested genetic testing was done. And when genetic testing was done, no surprise, there were 2 mutations that were found in the LDL receptor gene. Her cholesterol level was 412, and she underwent angiography, and that showed widespread coronary disease that resulted in the placement of 3 stents. So she definitely met the criteria of FH. And again, Dr. Gulati had mentioned before that we can use Simon Broom and Dutch Lipid Clinic scoring, both scores that we use to take a look at does an individual have FH. So she was diagnosed, and the next thing to do, along with to beginning to treat her, is to screen her first degree relatives for the risk of familial hypercholesterolemia. Okay, so Dr. Gulati, now that we have that, based upon Anna's presentation, what treatment regimen would you recommend right from the get-go?
Well, right from the get-go, I think, obviously this patient has been undertreated, being told her HDL is high, therefore her LDL is high. I mean, we want to get her on a high-intensity statin and ezetimibe, and then possibly on a PCSK9 inhibitor. But then, you can tell with this kind of LDL, you're going to need many medications. And, it wouldn't be unreasonable to start something like evinacumab on top of it if you're not at the target. Certainly, there's other questions with this patient, and I'm sorry we've kind of run out of some of our time here. But the patient who's already symptomatic too, I'd be worried that she already does have cardiovascular disease and want to work that up first and foremost
Right.
as well. And I think that we can't underemphasize the lifestyle too. Like, we know she's a smoker, so smoking cessation counseling needs to be given because she's at such high risk. But then additionally, talking about diet, talking about exercise, like we do with every patient, it cannot be minimized even in patients with FH. There's a lot of people who sometimes think that, well, you have this genetic disorder, diet isn't going to change, so it really doesn't matter what you eat. It still does, and we still counsel all our patients, even if they're at a healthy weight, that there might be things that they can stop eating or reduce, get more plant-based diet, focus. There's a lot of things we can do for these patients. And then again, all the things that you touched on, the patient education, patient resources. When this is a new diagnosis for someone, we really need to be able to talk to them about this, and what next, what to expect, the whole idea of genetic testing and genetic counseling, and who can treat their children, different ages. Maybe you don't, maybe they need a pediatric preventive cardiologist, but sometimes that's the only person available in certain communities is the adult cardiologist. So all of those points, I think, need to be discussed.
One question: how soon would you get the patient back in there? Would you wait, 4 months, or would you start high intensity statin, ezetimibe, and get PCSK9 on board? And then how quickly would you bring them back in?
Yeah, for this kind of patient, again, hopefully work up symptoms to bring in relatively quick. It's be quite overwhelming to get this diagnosis and then to implement everything. You throw a whole bunch of medication at somebody, and you won't be able to follow. If you do it stepwise, you might feel delayed in treating them. But if you give them a lot of medications, if they do have side effects, they do need a check-in. There's very great reason to have a team approach with this, is to see them quickly in about 4 to 6 weeks. If you initiate medication, work with your nurse practitioners, work with your pharmacists. I think most of our lipid clinics use some type of format with that, so that they can at least have a person to touch base with, and then continue to follow, if you add in a new medication, you want to see them again. It can be rewarding to the patient to see the cholesterol come down, and to also understand you can't just stop that medication because the number is better. The number, as we all know, will go back up if you stop the medication. We do need to know about side effects. So those things too are important when we use these new medications that we all are just learning about. Knowing if the patient is tolerating them is important for them and important for us. So I think that this is, the early and often touching base. And even in this days of COVID, where sometimes patients are less willing to come into our clinics, this can be a great telemedicine visit where they go get their blood work, and then you have the telehealth visit, and then they can ask their questions. They can actually be prepared and write them out, and their family can be sitting with them actually at these visits. And you can also talk about what does the family members need as well, in sort of general terms about who needs to be screened, providing education. I think all of that can happen in these visits.
Yeah, those are all excellent points. Unfortunately, I think we have to move on.
Yeah, I do. And I'm very sorry, because you guys have written in some great questions. I hope we've answered them. Actually, I looked at quite a few of them, and I do think we've answered many of these questions. If there's a way for us to online answer them, we will do our best on both social media platforms. But we are going to wrap up here. And so this is just hopefully what we've covered here today with you is, the importance of aggressively managing severely elevated LDL cholesterol, particularly in our patients with homozygous FH. Our goal is to reduce atherosclerotic cardiovascular disease and cardiovascular mortality. We've discussed today the importance of genetic testing, as well as the importance of cascade screening in patients identified with FH. Certainly, the current standard of care therapies offer benefits. We're really lucky to have so many different therapies to offer our patients with homozygous FH. In the past, we did not have those. And now, on top of that, we have newly approved agents that demonstrate potential. Certainly, they lower LDL cholesterol, but the exciting thing is to see if they improve outcomes for these patients. So thank you again for being here with us today. And we're going to move on right now to the post-test polling questions. Don't forget to do these. And again, for the viewers online on social media platforms, please use the link provided to access the post-test so you can get your CME credits. So again, the first question here, again, you can choose now your right answer in terms of what percentage of patients are with FH are undiagnosed. And Kathleen, feel free to answer if you want the question here. I think that
I think everyone is clearly on board with this. It's very underdiagnosed. That's what we wanted to get the point across of, and that it's hidden in plain sight for us. We just need to look at it. So get
90%.
patients tested and look at family histories, and let's get them treated.
Yeah, 90%. So we'll go on to the next question. You guys pretty much all got that one right. So this was the 28-year-old woman with homozygous FH, two children, an older brother. Who else warrants screening? And hopefully you heard clearly from us that all her first degree relatives are part of that cascade screening. And I see over 96% of people saying this. So that's great. So screen all first degree relatives.
Great.
Our next question here, 27-year-old patient with a positive genetic test, confirmed diagnosis of homozygous FH, taking ezetimibe and rosuvastatin every other day because of low tolerance. Which of the following therapies would you recommend next? And I'll let you answer this one, Kathleen.
Yes. Okay. So they're taking ezetimibe and rosuvastatin. So the next thing that we could try could definitely be one of the PCSK9 inhibitors. And we see 93% of folks answered that as well. So pretty much everyone is on board with that.
Yep, that's great. And then the last question is, what practical strategies can the healthcare team provide to ensure a patient adheres to their medical therapy or their different treatment options? And I'm just waiting for the right answer, which looks like the majority of people are answering it, is really direct our patients to these online resources for patient education that are provided for and created for patients through our national lipid and cardiology organizations. I think we've given you some great examples of those. So I think that's why they're there to be used. And if you have any suggestions for PCNA or for ASPC, you can always send them to either of us, and we'll make sure that we're always interested in making better tools as well. So again, I'm sorry about that. We don't have enough time for questions tonight, but definitely stay online. You'll be automatically redirected to the program evaluation, so you can request credit as well. And we'll find some way, if we've missed some of your questions, we'll try to figure out a way to answer them for you. Thank you for your attention. Sorry for going a little bit over tonight.
And thank you for allowing us to come into your homes and your offices tonight. We truly appreciate it. Thank you.